So hello everyone and welcome to the case 12 of this Osce series, and today we'll be discussing a very important set of questions from a single topic which is very frequently asked in the Vivas as well as short notes and theories. So let's start with the first case of the set. So here we have a 40-year-old truck driver with cognitive, behavioral and motor dysfunction along with some tremors and gait disturbances, and I have provided you with T1 weighted images as well as flare images of the axial section of the brain. So based on these images, what do you think the diagnosis is and what are the differentials for this condition? I'll give you some time to appreciate the findings. So on T1 weighted images, we can see that there are some ill-defined confluent hyperintensities that are seen in bilateral centrum semiovale and periventricular white matter, and these corresponding areas show hyperintensities on the flare images. Symmetric confluent hyperintensities are seen. And also there are some involutional changes that are seen in the brain parenchyma, some volume loss that is seen in this 40-year-old. Symmetric hyperintensities with involutional changes and corresponding hypointensity on T1 weighted images. There was no post contrast enhancement as such that was seen, and no restriction on DWI. So the findings were bilateral periventricular and deep white matter, symmetric T2 and flare hyperintensities, and the areas of abnormality demonstrate no evidence of mass effect, abnormal enhancement or restriction, and mild diffuse brain atrophy was also observed. So based on these findings and also the history that he's a truck driver along with some gait disturbances, motor disturbances, tremors, the diagnosis is HIV encephalopathy. So HIV encephalopathy or HIV associated dementia corresponds to a neurological clinical syndrome seen in patients with HIV infection, and it demonstrates a symmetric periventricular and deep white matter hyperintensity with relative sparing of the subcortical white matter and the posterior fossa structure. So this is very important, that there is relative sparing of the subcortical white matter and the posterior fossa structures, and these confluent or patchy hyperintensities show hypointensity on the T1 weighted images. This is also very important, and this is along associated with atrophy of the brain parenchyma, and there is no mass effect or enhancement that is seen in this particular condition. So an important differential for HIV encephalopathy is progressive multifocal leukoencephalopathy, which we will discuss later in our slides. So here we have another case, a retropositive patient with altered mental status, motor deficit and gait ataxia, and I have provided you with T2 weighted images and flare images. So based on these images of the axial section of the brain, what do you think the diagnosis is, and also what are the signs that can be appreciated, radiological signs on these images? I'll give you some time to appreciate the findings. He's a retropositive patient, and we can see that on flare images there is hyperintensity that is involving the white matter and also the subcortical fibers, and it is asymmetric in distribution. Here this hyperintensity that is seen on T2 weighted images axial section, we can see that the splenium, this hyperintensity is actually crossing the splenium to reach the other side. There is no mass effect that as such that is seen. These are few other images of the same case. Here the posterior fossa is also involved in cerebellum, and striking feature here that we can appreciate is that the dentate nucleus is relatively spared. These are also some hyperintensities that are seen in the white matter. Again the same manifestation, a manifestation of the same disease or entity. So what do you think the diagnosis is? So the diagnosis here is progressive multifocal leukoencephalopathy, which is actually a demyelinating disease caused by JC virus, which infects the oligodendrocytes, which are responsible for myelination. It presents in three clinical contexts, that is PML due to immunocompromised state, PML which is simultaneously associated with development of iris, and PML which is actually worsened by iris. So coming to all the important signs that are seen in the progressive multifocal leukoencephalopathy and were seen in the uh, slides, that in the images that I had provided, starting with the Milky Way sign. So here we can see that on T2 weighted images, we can see that there are punctate hyperintensities that are seen, which look like the Milky Way, all the galaxies in the Milky Way. So then coming to barbell sign, which is actually a confluent flare and T2 parieto-occipital abnormalities with thin continuation of the signal abnormality across the splenium. So here we can see that both the parieto-occipital regions are involved, and along with that the signal abnormality crosses the splenium. And there is no mass effect as such, and this helps it to be discriminated from other lesions which cause enlargement of the splenium, like inflammatory or neoplastic processes. There is no mass effect, and this signal intensity is actually crossing the splenium. This is barbell sign, looks like a barbell. So coming to another sign that is seen in the posterior fossa PML, that is a shrimp sign, which is actually an MRI marker of cerebellar PML, which is characterized by T2 hyperintensity in the cerebellar white matter, abutting but sparing the dentate nucleus. So this is the T2 hyperintensity, which is abutting but sparing the dentate nucleus. So white matter lesion resembles a shrimp. This white matter lesion actually resembles a shrimp, with the dentate nucleus outlining the belly of the shrimp. So the dentate nucleus is forming the belly of the shrimp, while the broader areas of involvement at the middle cerebral peduncle correspond to the head of the shrimp, and the narrower area of involvement in the middle medial white cerebellar white matter correspond to the tail. So this is the head, this is the tail, and this is the belly. So coming to the broad topic, that is the CNS manifestations of HIV infection. So HIV is actually a neurotropic virus, and it enters the CNS by crossing the intact blood-brain barrier, and it affects CNS by four major mechanisms. So if we remember all the CNS manifestations of HIV under these important four headings, we'll never forget it. That is directly by the HIV virus, opportunistic infections because of the HIV virus, neoplasms in the immunocompromised host, and the treatment-related complications. So starting with the first subheading, that is CNS manifestations caused directly by the virus, which includes three important entities, that is HAND, HIV associated neurocognitive disorder, which includes mainly HIV encephalopathy, which we have already discussed. Then comes HIV vascular myelopathy and HIV vasculopathy. So HIV vascular myelopathy typically involves the cord. So mainly the manifestation is of atrophy of the cord along with some signal change. It is caused mainly because HIV infected mononuclear cells secrete neurotoxic factors, and another contributing factor is there is impaired ability to use vitamin B12, and hence there is manifestation similar to subacute combined degeneration of the cord. That is, the dorsal column of the cord is mainly involved. Then comes HIV vasculopathy, which is associated with large hemispheric strokes because it involves the large vessels. So hand, HIV vascular myelopathy and HIV vasculopathy are the manifestations in the CNS caused directly by the HIV virus. Then comes infection, the most common infection being toxoplasmosis, and then another important infection which is commonly asked is progressive multifocal leukoencephalopathy. Others being CMV infection, fungal infection like Cryptococcus, Candida, TB, neurosyphilis. Then important CNS tumor that we have to remember in case of HIV setting is primary CNS lymphoma. And some treatment related complications include IRIS, that is immune reconstitution inflammatory syndrome. So here we have another case, a retropositive patient with history of seizures, and based on the images that I have provided, what do you think the diagnosis is? So these are the T2 weighted images axial section, and this is the T1 post contrast image. So here we can see that there are multiple ring enhancing lesions in bilateral basal ganglia, and here we can see a large concentric lesion. So what is this sign and what is the diagnosis? In case of retropositive patient, concentric involvement, that is hyperintensity, hypointensity, hyperintensity. concentric lesion along with extensive edema, ring enhancing lesions in bilateral basal ganglia. So diagnosis is actually very clear in this case, that is toxoplasmosis. So neurotoxoplasmosis or cerebral toxoplasmosis is an opportunistic infection caused by the parasite Toxoplasma gondii, and it typically affects patients with HIV or AIDS and is the most common cause of cerebral abscess in these patients. So coming to that important sign, that is a concentric target sign, which is a typical sign of cerebral toxoplasmosis, and it is seen as a concentric rings of hyperintensity and hypointense signal alternatingly. And there is strong perifocal edema also that is seen on T2 and FLAIR images. So pathologically, the toxoplasma lesions have three distinct zones. Because of that, this concentric target sign is seen. That is a central avascular zone of coagulative necrosis, intermediate vascular zone containing numerous organisms, and outermost zone of encysted organisms. So this is another case which is an important DD for toxoplasmosis, a retropositive patient with headache. So what is the diagnosis and the differential? So this is actually a T1 post contrast axial section where we can see that there is intensely enhancing, homogeneously intensely enhancing lesion which is seen. So in case of a retropositive patient, we have to think of primary CNS lymphoma as a possibility here. And how do we differentiate CNS lymphoma from toxo? So there are important distinguishing points based on their distribution, enhancement, and MRS. So primary CNS lymphoma typically demonstrates subependymal spread, whereas toxoplasma tends to be scattered through the basal ganglia and at the corticomedullary junction, where we saw in that case. And HIV lymphoma also is far more frequently solitary lesion, whereas toxoplasma usually has multifocal, multiple ring enhancing lesions present. So that is the distribution. Then comes the enhancement. And on CT as well as on MRI, both entities enhance following administration of contrast. But lymphoma may solidly enhance, whereas toxo usually demonstrates a ring or nodular enhancement. Then comes MRS. Both the entities demonstrate increased lipid lactates, although this tends to be less marked in lymphoma. And lymphoma typically demonstrates a marked increased choline, whereas it is reduced in case of toxo. So coming to the last part of the discussion, that is neuro-iris, that is immune reconstitution inflammatory syndrome, which is actually of two types: unmasking iris and paradoxical iris. Unmasking iris occurs when the antiretroviral therapy reveals a subclinical, previously undiagnosed opportunistic infection. That is, because of that immune restoration, it leads to that immune response against the living organism. So here the brain parenchyma is damaged both by the organism as well as the incited immune response. Whereas in case of paradoxical iris, which occurs when the HIV patient who has been successfully treated for an opportunistic infection unexpectedly deteriorates after an initiation of antiretroviral therapy, it occurs because of restoration of previously suppressed immune response or reactivation of the memory cells, which actually cause more damage to the brain parenchyma. So these are the two types of neuroiris. So this finishes our topic on CNS manifestations of HIV. So coming to the pulmonary manifestation, so this is a very important HRCT picture, which is actually a spotter. So this is a retropositive patient with chronic cough, and I want you to tell the findings and the diagnosis. So I want you to write the diagnosis in the comment section, and this is actually a quiz. The answer will be revealed in the next video. So this is an HRCT image that has been provided, axial section, and this is a retropositive patient with chronic cough. So what do you think the diagnosis is in this particular case?